as we said previously, endoscopy flexible and rigid. You examine the patient for polyp, for abnormality of the osteometric complex, for mucosa, color of the mucosa, for deviated septum. Culture and sensitivity, and CT scan show the extent of the disease, complicated anatomy, asymmetry of the skull base, and orbital blowout fracture. CT scan should be done before surgery and in case of antibiotic failure after 6 weeks of maximum medical treatment. Usually there is a 40% of normal population have a thickening of the CT scan. Put in your minds, this is very important notes. 40% of normal population have a mucosal thickening of CT scan. Puts in your mind this notes. MRI good in soft tissue, in orbital or intracranial communication. Allergic evaluation of the patient's failed of medical treatment or even failed of surgery. You should evaluate for the allergy, as 60% of chronic sinusitis without polyp is caused by allergy. The black color is aerated and the opacity in the side. Now for the differential diagnosis, put in your mind chronic sinusitis could be part of cystic fibrosis or primary dyskinesia, could be fungal infection, could be systemic disease. Gastroesophageal reflux may be a cause in chronic sinusitis. Now, summary of diagnosis of chronic sinusitis without polyp. Now, as I said, the chronic sinusitis without polyp is an inflammatory disease, it's not infectious disease, characterized by 2 or more symptoms, one of which should be either 2 of these symptoms should be present. One of these 2 should be either nasal blockage or nasal obstruction or congestion, or nasal discharge anterior or posterior, postnasal, plus minus facial pain or pressure, plus minus reduction or loss of smell, or and either. يعني دول الأربع نقاط اللي بالكرونيك ساينسايتس. حتى ننجز الكرونيك ساينسايتس نحتاج أول نقطتين، واحدة من عندهم تكون موجودة، يا إما اثنيناتهم أو واحدة من عندهم موجودة، زائد الفيشيال بين، زائد الناقص reduction من loss of smell. and either endoscopic sign اللي nasal polyp, mucopurulent discharge primary from the middle meatus، أو edema mucosal obstruction primary in the middle meatus، and or CT scan finding اللي هو من thickening بالاوستيوميتال complex or sinuses for at least 12 weeks without resolution. حتى أشخص الكرونيك ساينسايتس بدون بوليب لازم أكون عندي واحد من الاثنين symptoms اللي هو nasal blockage أو nasal discharge plus minus facial pain أو reduction and endoscopic sign and or CT finding. All these presentation should be for 3 months without. Now in the treatments, antimicrobial, anti-inflammatory, and mechanical. Medical treatment should be continued for 4 to 6 weeks of antibiotics. The cause should be when treatment give a particular attention to adenoid allergy. Personal habits, smoking, alcohol, endogenous, environmental or work situation, smoking or dusty surrounding. Antibiotic, usually macrolide. Why macrolide? Because macrolide is anti-inflammatory and infectious. Nasal steroids spray with short course of oral steroid less than 3 weeks. طبعا after 3 weeks نحتاج تبرك. Culture directed topical antibiotic بالجنتاميسين أو ميوبروسين، هذا local antibiotic. Nasal douching daily before nasal steroid spray help in some refractory cases. Saline nasal douche اللي هو azotonic saline before use of nasal steroid. Allergy treatment, antihistamine topical less effective of systemic. Anticholinergic بالإبراtropium bromide in vasomotor rhinitis. Leukotriene modifier Montelukast أو Xylostine may be helpful in especially asthmatic patient on aspirin desensitization. Or in cases of associated allergic fungal sinusitis, desensitization immunotherapy and antifungal. Really in immunotherapy you will take in the next week the lecture of the allergy, and Dr. Adil will talk in details about immunotherapy in the allergic patient in nasal decongestant less than 1 week because of rhinitis. Surgical treatments after maximal medical treatments for chronic sinusitis اللي هي 4 to 6 weeks fail. Symptomatic patient and there is evidence of persistent mucosal disease or sinus obstruction on CT scan or endoscopic evaluation, surgical therapy may be necessary by functional endoscopic sinus surgery. Sarcoidosis is systemic disease and TB and the mucosal ancillary abnormality can result in failure of the surgery. Endoscopic sinus surgery indication chronic sinusitis, acute recurrent, nasal polyp, repair of CSF leak, blood fracture, dacrocysta, ستاروتومي. This indication of endoscopic sinus surgery. يعني ببساطة هاي الأشياء نقدر نوصلها باستخدام السكوب بدون ما نسوي open surgery. السكوب والinstrument enter the nasal cavity and the nose and work on the camera. The summary of the endoscopic sinus surgery. يعني ندخل السكوب والانسترومنت اللي نشتغل بيها داخل النوز بدون open surgery. الكونترانديكيشن بالفس in presence of intracranial complication like acute infection بالmeningitis, parosteal or epidural abscess, cavernous sinus thrombosis without visual loss, hypoplastic sinus, distorted anatomy of the sinus, presence of acute infection. All these is contraindication for summary of medical treatment of chronic sinusitis: allergy and irritant avoidance, douching by isotonic saline, corticosteroid, usually topical, maybe forever, and short course of oral, decongestant for 1 week, systemic not preferable, antibiotics preferable macrolide, antifungal, antileukotriene بالasthmatic patients especially with subther trial, aspirin desensitization, والimmunotherapy بالallergic patients and other therapy. This diagram shows the treatment of the chronic sinusitis with polyp. إذا mild disease, intranasal chronic corticosteroid for 6 to 8 weeks. If good response, continue maintenance therapy. Poor oral response, إلى surgery. إذا moderate or severe, antibiotic for 6 weeks plus short course of oral steroid, intranasal corticosteroid وsaline irrigation, allergic evaluation. Good response, poor response, CT scan, normal, consider other differential diagnosis. If positive, endoscopic sinus surgery. Good response, okay. Poor response, evaluation of systemic disease or ciliary problem of allergic problem. This is without polyp, either intranasal chronic corticosteroid with antibiotic or a short course of steroid. Good response, continue maintenance. Poor response, CT scan. If positive result, endoscopic sinus surgery. Good result. Poor on allergic evaluation, could be celiac, could be systemic disease, if even the surgery failed. Now continue with the last subject in our lecture today is fungal sinusitis. Fungal sinusitis, we talk about acute invasive, chronic invasive and non-invasive اللي هو fungal bore, saprophytic fungal and allergic fungal sinusitis. The fungal infection of the paranasal sinuses are uncommon and usually occur in an individual who is immunocompromised or immunocompetent. In most common pathogen who are Aspergillus and the mucor species, the Aspergillus can cause non-invasive and invasive. When invasive is characterized by dark, thick, greasy material found in the sinuses. Non-invasive cause symptom of sinusitis, and the sinus involved are opacified on the CT scan. Culture in the sinus rarely demonstrate the fungus, however the fungus usually is suspected upon reviewing the CT scan and detected on removal of the secretion from the sinus. The invasive infection causes tissue invasion, destruction of the adjacent structure like the orbit or the CNS invasion. The fungal infection of the paranasal sinuses can manifest as two distinct entities. The more serious infection occur in patient diabetic or an individual who is immunocompromised, characterized by invasiveness, tissue destruction, and rapid onset. Early detection and treatment are vital for this infection due to high mortality rate. Non-invasive infections are chronic and usually treated for extended period as a chronic rhinosinusitis before the condition is recognized. This CT scan, coronal view of the nose and paranasal sinuses. On the right side, the sinus is clear, aerated, black color. On the left side, opacity on the ethmoid and of the maxillary sinus. What the characteristic feature of the radiological finding of a fungal rhinosinusitis is the hyperdense, not homogeneous. This is not so dark, and this is dark, this is dark, this is not so dark. Yani heterogeneous. Heterogeneous, not homogeneous, not opacified completely the same color. Characteristic of fungal rhinosinusitis. Non-invasive, two types, allergic fungal and sinus mystioma. Most common fungal type هو carviolari اللوناتا and aspergillus fumigatus. Fumigatus and the mutaceous fungi most common cause sinus mystioma. The invasive, acute fulminant type, which has high mortality rate if not recognized early and treated aggressively. The chronic granulomatous and non-granulomatous type. Curicamilla, mucar, rhizomucar. These types of fungi that causes the chronic invasive fungal sinusitis. Fumigatus is the only fungus associated with the chronic invasive fungal rhinosinusitis. In pathophysiology, in allergic fungal rhinosinusitis is prevalent in this group and caused to be a trigger mechanism behind the allergic fungal rhinosinusitis. Allergy. Patient are immunocompetent, have asthma, eosinophilia, and elevated total fungal specific immunoglobulin E concentration. Surgery reveal greenish black or brown material, allergic mucin, has consistency of peanut butter mixed with sand and glue. peanut butter mixed حقيقة يسموه مثل الفول السوداني sand and glue مثل يعني هو مثل يعني حقيقة مثل الطين يعني هو peanut butter mixed يعني هو مثل الفول السوداني مثل الطين عاد بيه حصى صغار يعني هو هيك بنلقيها بنفتح بالسيرجري هيك نلقيها يعني. Allergic mucin and polyp may form partially calcified expansal mass, prehensile mass, obstruct sinus drainage, growth of the mass may cause pressure induced erosion of the bone, rupture of the sinus wall, occasionally leakage of the sinus content into the orbital brain. The rupture of the nasal bone is not so accepted term, is not rupture, it's erosion. Sinus mystioma, unilateral, especially in the maxillary sinus involvement. Mucopurulent, cheesy or clay-like material present at the time of surgery. This is like crayon sand. Patients has sinusitis myostoma are immunocompetent, allergic condition and fungal specifically less common. Allergic fungal sinusitis. Acute invasive بالimmunocompetent patient, immunocompromised patient. Rapid spread of fungi through vascular invasion بالorbit and CNS. Common in patient diabetes and immunocompromised. Patient acute vision. Severely ill, fever, cough, nasal discharge, headache, mental state change, require hospitalization. Invasive fungal sinusitis, chronic invasive fungal sinusitis, slow growing progressive fungal infection, low grade invasion process and usually occur in patients with diabetes. Orbital epic syndrome characterized by decrease in the vision, clear motility due to mass in the superior portion of the orbit usually associated with this condition. Down in the presentation, allergic fungal rhinosinusitis, usually the patient is immunocompetent, coming from chronic sinusitis, facial, like chronic sinusitis, facial pressure, headache, nasal stiffness, discharge, cough, and should be suspected in intractable sinusitis and nasal polyp. Some patients present with complication like proptosis, and this patient could be atopy and had multiple surgery by the time of diagnosis. CT of the sinuses reveal opacification with concretion and calcification or calcification. In sinus myostoma, similar to that of any patient with a chronic sinusitis, maybe thick discharge, post-nasal discharge, facial pain, nasal obstruction, cacosmy. Cacosmy is mean bad smell from the patients, revealed by the others. The chief main complaint is blowing of gravel-like material from the nose. gravel يعني gravel يعني هو مثل مواد مثل الطين، يعني مواد مثل الطين تصير يعني لايك بنوت عن sand and يعني مثل الطين صراحة، مثل الطين يكون يعني. This bowel sinus center diagnostic criteria allergic fungal sinusitis. Usually the patient هو immunocompetent و nasal polyp و CT finding اللي احنا قلنا heterogeneous. Presence of allergic immunosine و positive fungal culture or positive fungal HIV or fungal staining. This is the CT scan. On the left side, the heterogeneous. My dear students, concentrate on this CT scan, and the right side is black colors mean normal aerated maxillary sinus. In the left side is heterogeneous, characteristic for the fungal sinusitis. In the other slide, another picture, this is the concretion of the fungal wall, and this is the sinusitis, opacity of sinusitis. This CT scan, opacity, heterogeneous, and this is the fungal. This is the picture of the fungal. Picture of the fungal like peanuts. Many treatments, patient usually بالfungal sinusitis invasion hospitalized, يكون very sick and fever, cough, nasal discharge, headache, mental state changes, high index of suspicion for early diagnosis is critical, especially in individuals who are immunocompromised. Sinus symptoms include dark ulcer on the septum, turbinates, palates, late stage sinus symptom of cavernous sinus thrombosis are present. Mucormycosis is one of the high mortality rates, really high mortality rate. In chronic invasive rhinosinusitis fungal, which is present with long-lasting sinusitis, symptoms are not acute, fever and mental state changes are absent. Orbital apex syndrome, characterized by decrease in the vision and ocular mobility due to mass in the superior portion of the orbit. Usually associated with this condition, nasal examination finding can be minimal, however finding from eye examination can be positive. Lab test. Invasive, usually the immunoglobulin concentration is high, less common in patients with sinus mystioma. In CT scan, بالradiology, previous two slides I talk about the finding of the CT scan. MRI بالorbit والtracking is good. بالMRI show low in signal intensity, suggested fungal process versus solid mass in allergic fungal sinusitis. MRI help in evaluation CNS spread in invasive fungal sinusitis. Histological finding بالallergic fungal contain intact and degenerated eosinophilia, charcot-lined in crystal, cellular debris, and spare hive. The mucosa هو mixed infiltrate of eosinophilia, plasma cell, and lymphocyte. The mucosa is not invaded by fungi, اللي هو بالinvasive fungi, بالinvasive mucormycosis sinusitis. Allergic immunosine present in sinus mystioma. This sinus contain dense material اللي يتألف من hive separated from but adjacent to mucosa. Sinus mucosa is not invaded. This is important بالhistopathology بالsinus mystioma. Acute invasive reveal hive invasion of the mucosa. Invasion of the concentrate of this term. الhive invasion mucosa بيسمى mucosa والblood vessels including carotid artery, cavernous sinus, vasculitis, thrombosis, hemorrhage, and tissue infarction. Necrosis of the mucosa, submucosa, blood vessels, low-grade inflammation observed in chronic invasive fungal sinusitis. Granuloma with hematonucleated giant cell with the pressure necrosis and erosion observed in granulomatous invasive fungal sinusitis. Now in treatments, all the fungal sinusitis is treated surgically. Medical to control of the disease and help the surgeon. Allergic fungal, the treatment best of choice is the surgery. Systemic steroid may be indicated once the surgery is performed and diagnosis confirmed. Topical steroid helpful postoperatively. Aggressive saline salt water wash are recommended. Immune therapy for specific allergy is controversial. Systemic antifungal or antifungal Their role is controversial. Course of oral itraconazole 40 mg daily for 1 month compared over 3 months need regular monitoring of the liver function and has shown good results. Allergic fungal. The sinus myostoma is surgery. No further treatment is indicated for except for control of the underlying disease, يعني infection or allergy. The chronic invasive fungal sinusitis is surgery. Maybe need medical treatment, systemic antifungal, إذا invasion diagnosis. إذا amphotericin 2 gram totally is recommended. This can be replaced by ketoconazole or itraconazole once the disease is under control. Invasive fungal acute invasive fungal sinusitis is emergency. Once the condition is suspected, initial systemic antifungal treatment after surgical debridement. High dose of amphotericin B recommended. Oral itraconazole can replace amphotericin B once the acute stage has surpassed. Treatment of the underlying immune deficiency is possible as desirable. But allergic fungal surgery is the best choice. Goal of surgery is debridement of the mucin and polyp present in the involved sinus, restoration of the sinus aeration. Usually the surgery is by endoscopic. Externally, if the endoscope is not possible or contraindication. Ventilation of the sinus is essential to prevent relapse or recurrence of the disease once the disease is eccentrated. Myostoma, usually the treatment by surgery, by endoscopic sinus surgery to aid the sinus. No further treatment except for underlying condition. In endoscopic contraindication, you can reach the sinus externally. With acute invasive, perform emergency surgery once condition suspected. Perform radical debridement of the necrotic tissue till the normal, healthy, reached and bleeding occur. Debridement achieved either externally or endoscopic sinus surgery. Chronic invasive, usually the treatment is surgery, and usually the treatment by fungal may be before surgery to control the disease and continue after the surgery, either endoscopic or externally according to availability or extension of the disease. Follow-up, allergic follow-up, allergic fungal sinusitis, the long-term follow-up is requirement. Achieved this by endoscopic examination, debridement in the office, short course of systemic steroid, maybe administration if any sign of relapse or recurrence are seen. Surgical debridement may be necessary if the systemic steroid failed to control disease, and thank you for listening.